So
Mhm.
we're here to talk about what's going to happen in healthcare once this COVID-19 hit, this first COVID-19 hit has passed. Our very special guest today is Lucien Engelen. Is that right? Lucien Engelen?
Yeah,
Okay.
that's good.
Engelen, who recently published 3 pieces on LinkedIn in which he pondered about the problems we're going to face right away after this first phase of COVID-19 and explained why this is the best time for us to rethink and reshape the whole healthcare system. I'm very pleased and thankful to have him here with us to talk about this investigative subject. And let me say that anyone who might have the opportunity to have coffee with one of his or her esteemed authors is a privileged one. I'm having my second opportunity of having a coffee with Lucien, and I'm very happy. Thank you very much. Let him introduce himself so we can start our conversation. Lucien, please make yourself comfortable. The virtual room is yours. Once more, thank you very much.
Thank you very much, Flavio. I keep great memories to our first in real life coffee back in the days in your beautiful country. And also about all the things that we were talking and bragging about back then. A lot has changed since. So back then I still was at Radboudumc University Medical Center, where I created and founded the Radboudumc Reshape and Innovation Center, which was merely at the, let's say, the intersection of technology and patient empowerment. And after a career in emergency medical services, which we had at our family businesses, transferred into a bigger ambulance services, then to Radboudumc University Medical Center. And after about like 12 years, I quit my job because I thought that the change in healthcare no longer alone would come from inside of healthcare. The push from outside healthcare towards health and healthcare is way bigger and also has a bigger impact than from healthcare outside alone. So that was, for me, was the reason to quit my job. I was also, and still am involved in Singularity University, Silicon Valley, at the exponential medicine track from our big friend Daniel Croft. And I joined for 3 days a week the Deloitte Center for the Edge. We're not employed as Edge Fellows. We are merely helping Deloitte and its clients to see what's coming up at the horizon, but also kind of flipping the mirror also backwards to Deloitte to say, maybe you should change your own model as well. Next to that, also having a speaker practice where I traveled in the past tense the world to share and also drink coffees with people like Flavio and his colleagues to see what's happening, what's needed, and how could we connect people and technology in the end of the day to create a more sustainable healthcare system, not only for patients, family, and formal care, but also for professionals. Back to you, Flavio.
Okay. Nice. So let's begin here with some questions, Lucien. On your first article that we mentioned, you raised the flag of a subject that has been right there for everyone to see, but we have been kind of focused only on that flattening the curve thing. And that's okay, we needed to. But with this forced standstill we are living in, all kinds of healthcare interactions needed to stop. So all these postponed treatments, missed evaluations, lost controls, won't be gone for good. They are right there, just around that curve we are flattening, and they are coming around for us to deal with them. We health professionals in healthcare are so eager to go back to our routines that we are missing the point here. Maybe we, the healthcare system, are not that prepared for being back. So I think the best way to start this conversation is hearing your impressions about why the return to our former routine is going to be a big challenge for the whole healthcare system.
Well, so maybe you can switch on that I can share some screens, then if that's possible at your end, so I can throw in 1 or 2 slides for you. Merely the reason is this: in my first article of my trilogy, I debated that it's not all about flattening the curve. It should be about flattening the curves, as in plural, because there is not only one, there's more than one curve. The first one that we've seen was flattening the ICU curve, obviously for all good reasons in that. But all those pictures that you've seen with that peak and that longer stretched curve, they always, and I think the economists started with that, put that line in it that people would say, if we're able to flatten the curve, we could stay underneath the max capacity of healthcare. Okay. And I had some big trouble with that approach, because that suggested that prior to the COVID-19 era, there was already a system that was able to cope with the demand, which we all know that was not the case. So that for me was the first issue that I had with those kind of graphs. The second issue that I had is that, oh yes, we should really embark on that flattening the curve, but also be aware of all the postponed interventions and operations, and even the minor interventions that could grow into more major interventions in the end of the day. That was the second one. And the third one really boggled my mind and still does. We all seen in every country, just like in Brazil and in the Netherlands and the US and everywhere, we will bring in people that were not ICU trained to help either as a buddy or else in a different way to assist in real ICU challenges, with also all the big impressions that people gotten into it. And people weren't trained for that. And so first of all, the PTSS kind components, post-traumatic stress syndrome aspects that we would suggest or that we could expect to see, not only are starting to occur already, but meanwhile we get this second curve of all the postponed healthcare that was still in waiting mode. So there's no time to really breathe just in between for them. So people have been on watch and on duty for like 14 to 16 or 18 hours of shift, thought that they could be a bit at ease for now, and now the second and the third wave and all the other waves are just hitting the shore, let's say like that.
Okay, yeah, it's going to be a problem. In your opinion, a good way to work or to help working this situation, if not the best one, is embrace all those digital solutions. As you wrote, we have been, then I quote, we have been pregnant of digital health, and now during this impressive pandemic, it came to life through a C-session. Telemedicine is a good example on this matter so far. Talking about applying digital solutions on healthcare. First question is, why do you think healthcare is so resistant to new tech and digital solutions?
Well, yeah, first of all, I think indeed we for years were pregnant of digital health, years and years, and we've seen now during this COVID-19 that, for instance, just something like video conferencing that we are doing right now, all of a sudden kicked in healthcare. It's not new. We were working on this like 10 years ago, but the resistance was often not really resistance, Flavio. It was more like it just didn't happen. People were uncomfortable with it. They said, my patients don't want to use it. We're running in the Netherlands for, I think, the 6th or 7th subsequent year, what they like to call the e-health monitor run by the Dutch government. And for all those years, there was this clear resumption into it that over 75% of all the patients being interviewed said, just bring me digital health, I'm fine with that. I really want to use it, but nobody is offering it to us. On the other hand, the same professionals that were interviewed said, nobody is asking, so they don't need it. So that's the gap that we're facing. I don't think it's hardcore resistance. It's more like bringing systems in together, like the legacy systems in healthcare often are very troublesome to bring new technology in that's not combined to our EHR systems. We now see, for instance, this uptake that molded into electronic medical systems, record systems. Video conferencing is embedded, and now all of a sudden it goes on a roll. The issue that I have with that is that, again, it's centered from out of the hospital. It's centered from out of the professional and not the other way around from the patient's family and informal care's perspective.
Once I began to work with this kind of thing, this technology and data science, I kind of got the feeling that we healthcare professionals, we are kind of hiding behind that the speech that healthcare is so complex, so we have to stay here on our security zone. So that's kind of,
you know, I don't think that healthcare is so complex. If you look into healthcare from a patient's perspective, let's assume from a patient's perspective,
okay,
everything you do added up, the whole trajectory of your quote unquote patient journey for 80% is blunt logistics, has nothing to do with medicine, nothing. It's you to take, needing to take a day off with your partner, travel to the hospital, find that latest parking spot way in the end of the hospital, and then you're just like, for your 10 a.m. appointment, you're 2 minutes prior to 10, you're at that front desk and somebody would say, hey, Flavio's running late, please take a seat. You know, that's the thing that we're looking at. So I understand that it's from a doctor's perspective and a nurse perspective, healthcare is complex with all the interdependencies. But the moment when you see and start to embrace it, like we've done now in this COVID pandemic, all of a sudden we see it really could help. Not in every case, not in every situation, but there are situations where it does work. So the thing we should do, I think, first of all, is that we really should bring digital healthcare tools into the curriculum of the medical students and also the nursing students. Because otherwise, if the sitting crew has been retrained and adapted and accepted to it, then all of a sudden there comes a new cohort of physicians and nurses, and we could start back again, you know. The second thing that's happening, I think, is that society, i.e. patients, family, and informal care, no longer accept that tools that they use in everyday society not are being used into healthcare. Sure enough, it needs to be secure. Sure enough, it needs to be privacy guarded, of course. But from that perspective, just look what happens in banking. That's as secure needed as for healthcare. So, you know, the other day I was thinking about this, Flavio. It's even in the language of healthcare professionals. You need to see the patient. And see the patient up until now has been sitting at your desk in your consultation room, and to see with this clinical notion. And people think that they lose some of that clinical notion when you start using digital tools. And it's not only video conferencing, but also remote monitoring. You can even, you can see anything. So this is a new paradigm shift that I think is being luxated, not specifically due to this COVID pandemic, but it has gotten a boost, certainly.
Okay. Talking about shifts, an important mind shift, as you wrote, is to stop narrowing our focus on healthcare, step back, and start seeing the big picture that is health in general. What are the hanging fruits on tech and digital tools that could help us or our institutions or our services to begin to change this focus right now?
I'm afraid those would not be technological tools. I think we need to open up for what's happening in the life of patients. You know, whenever we want to change something in a university medical hospital or in a GP practice or whatever, we nowadays, 2020, tend to reach to patient journeys, you know, patient journeys. And then we try to craft every step that patient takes. The reality is, it's not a patient journey. More often, it's a journey in one institution. And actually, not only in that one institution, in one department of that institution, and actually with one physician or one nurse. And the bigger picture is what Annemiek from Foundation Icona told me when I was crafting a slide for that. She said, head nodding, you're missing the big picture. It's not about the patient journey. It's not about the organization journey. And it's not about the professional journey. It's about my journey of life. And the minute when you start to accept that there's a broader focus other than that 1 hour out of that 8,765 hours that a patient with a chronic condition visits its physician. The rest of it, they're just on their own, those 8,765 hours. You're a guest in the life of that patient, and there's so much more that matters. And one of the things that I dearly adhere to is that physicians more and more no longer ask what's the matter, but more like what matters to you. That's the first step. And then you can bring in technological tools like digital tools or other ones to really craft and crave into the lives of patients, family, and the formal care to see how that really could work. You know, digital tools should stay tools. It's not a goal. It's not like we just shift in some technology. We should shift in technology whenever it makes sense, and also giving the patients a choice where they now don't have a choice. It's either or. You can visit the doctor's office or not, you know.
Mm-hmm.
That's not a choice.
Okay. Digitals are tools. That's fantastic.
Yeah.
Let's see. About you told us you touched that subject right before we began to talk about these tools. But let's talk about using personal information like social networks, buying patterns, bank account informations, reading preference, and so on, for building a health profile as personal as possible. How much we must invest on it, or how much important it is once there are many complex issues of data security and privacy involved. Is it worthwhile to deal with, in your opinion?
That's a good question. So the last part of your question, I cannot answer. Is it worthwhile? Because that always depends on the patient. If the things that you can do for a patient with a chronic condition, for instance, that could have more value than somebody that has a small intermediate healthcare problem that you as a physician can fix with one intervention. So it's a relative difficult question to answer. Is it worthwhile? The first part on that, I think we should not be building health profiles. I think we should give patients the ability, and in terms of not only having access to their own data, but also ownership of that data, to be able to grant whomever they think that's needed for their life and for their health and healthcare, to get a subscription on that data. So I don't think it's up to us as healthcare professionals. It's up to society, including the ethical debates that go with it, to make sure that you have access to the data that is about you and from you. It's basically, I think the analogy I made earlier on in an interview was, let's take banking. That you would step to your bank office, you would go to the front desk, and you would ask the bank clerk to say, "Can I see my bank statement?" And the guy at the front desk would say, No. That's not possible. You know, bad things could happen, you know. And I know it's a bit of a cartoon-esque kind of thing that I do right now, but nobody could imagine ever more that you would not own and have access, total control of the data about you. Sure enough, you cannot change your bank statement like all of a sudden there's $1 million more in it. That's what I can take. But whenever there's something that's not okay, you can see it, and then you could call the bank and say, "Hey guys, something's the matter." And I think the same should happen with health and healthcare. Okay.
So let's shift to this subject of empowering the users of healthcare system, society, and patients. The most important change in healthcare mindset may be this Copernican movement that you described as, and I find it fantastic, a Copernican movement, as a transforming, and I quote, transforming a system that currently revolves around the professional to one that revolves around the patient. At the first glance, one may ask, but healthcare is already all about patient. What is he talking about?
Yeah.
You took a great part of your Augmented Health care book for you to explain its concepts and applicabilities. And these concepts are all over your reasoning throughout your recent trilogy. So I would like to hear you explain what is the patient-first concept, why technology and digital tools, again, could be powerful enablers of this mind shift, and if possible, pointing out what digital tools, technology could help us today being closer to patients and shifting our framework.
Wow, so you got an hour? I think
Oh,
it's
yes.
like 16 questions in one.
Yeah, sorry.
So let me no, that's just joking a bit. So let me start with the first aspect of it. I think we're always talking about a Copernican moment. It's not the movement, but a moment. The Copernican moment, Copernicus was a scientist that back in the 1500s proved that the sun was not circling the earth, but it was the other way around. And that's what we tend to refer to as a Copernican moment, whenever the paradigm shifts. And I think the same happens for healthcare. Of course, it's all about the patient, but all the procedures, all the logistics, and everything that goes with it is institution-based, and it's not society-based. It's not aimed at the patient, it's aimed at the professional and the institution, and the patient has to adhere to it. And there's this great picture of Sir Luke's in the field, and you probably know that, where the physician, I think it was in the 1790s or something like that, in the late 1800 actually, where all of healthcare was stuffed in one bag, and the physician could visit the patient at their own home. And then the industrialization came and all the technology came, and then we started to build hospitals, and then we said, no, you need to come to us because we've got all the technology over there. Makes sense, Back in those days, that makes sense. Now, 2020, we got technology to say, let's do that the other way around for some aspects. We could bring some of those interventions, measurements, discussions, monitoring back to the homes or people, or even wherever you are with something at your wrist or in your ears or what have you. So to me, that's the shift. That's the Copernican moment aspect of that. And I think that also in one of my blogs, I said, I really would love to go from a reactive healthcare system now to a proactive healthcare system, where we would go from a centralized aspect into a distributed, like in networks, and in the end of the day, no longer from a system focused, but into a people-focused system. And that's exactly what I'm trying to bring across also, not only in my book, but also in the blogs that I write on LinkedIn.
Okay.
And technology can help in that, Flavio. It's not like technology is now all of a sudden the big thing. And again, I think maybe the best thing technology could bring is to bring back compassion, as in you have the time to really discuss with your patient what's the matter, and no longer what to discuss with your patient what matters to them, as opposed to what's the matter. And hopefully technology can do that. And I hopefully it will be a situation where the patient can choose. I worked a lot with young cancer patients, the AYAs, adolescent young adults with cancer in the age of 18 to 35 years. And they had to come to consultation every 6 weeks based on an oncology protocol to visit their oncologist at the hospital. And often for like 10 minutes. When we sat down with them, they said, we don't want to come every 6 weeks because last week I needed you for an hour and I was not able to get a hold on you. So maybe we're bringing that choice to use technology at some moments, and some moments you don't, to give more flexibility into it, and also to create more impact even as a healthcare professional for your patients.
Yeah. Technology maybe will buy us time to be more humans. Yeah.
I really hope so. I think there's this great TED talk of Abraham Verghese from Stanford. I don't know about the numbers that has been viewed. It must have been in the millions. And the title of the talk is The Power of the Human Touch. So this is Abraham Verghese from Stanford, you know, the temple of technology.
Yeah.
And he's trying to blend technology with that human touch. And with the human touch is everything that goes with it, from attention for your patient, real compassion where needed, and giving them the best advice that you can get.
Nice. Well, you began your third article with an observation. I quote, of all the factors that influence the average person's health, such as genetics of birthplace, access to health care accounts for just 6%. Yet the healthcare system soaks up 90% of all related expenditure. And so I would like to share this image. Let's share my screen here. Just a moment. This one. This is the image you used on your article. So
correct.
I would like to hear you to explain these statements, because I think it shows why this shift is so necessary. Also, you could explain why value-based care is essential to this context, please.
So what this picture shows, I think, and I, by the way, would not use the word soaks up 90%. I think this is reality. It's not like it's been intended like this. This is where healthcare has grown into, where for whatever reason, over time, we put the markers in a different place. We put the markers in a place where we would say, that's fine if you don't have good behavior for your lifestyle. We'll fix that afterwards, you know? And oh, by the way, that's reimbursable because you got coverage, you know? So no worries. So the reason I'm stating it like this is that when you look into these two graphs, there are some things you can influence. You cannot change your DNA, obviously. And the postcode is where you were born. It really matters if you were born in the upper class in Hollywood or in a different suburb in Los Angeles or a different city. But the behavior and the combination of that combined with access to healthcare, sometimes you need to fix stuff. That's where I really think things start to matter. So we all know that I think that like 50% of all conditions is undisputed based on somewhere related to lifestyle. So why is it that there's no insurance company, that there is no governmental program to reimburse positive impulses for that, for instance? If we start to shift from healthcare to health, not to replace healthcare, but to put the impact on a different place, let's be honest, we see a doubling on healthcare demand in the next 2 decades. We already have staggering burnout rates amongst physicians and nurses. We see a growing demand from patients to use it in a different way. So the system is going to implode. And the only way to really cope with that and create a sustainable system is to go more towards the healthcare aspect and also to combine that with a cross-industry approach. That was why I always show this picture. Yeah.
Okay. Let's start sharing. All right.
Everybody can see that we both have a screen at the right hand side just to look at the...
Just looking. And I'm trying to put this...
Where's the guy looking? You know? No, but so again, so from healthcare to health, I think that's very important. And that also brings in the notion of that we as healthcare cannot do this alone. You know, we need other industries. We need to create this cross-industry approach where, like I said at the start of our chat here, is that we need to have this broader perspective within the life of people. If everything that a patient with a chronic condition that would benefit from a better lifestyle change only would be able to benefit from that 1 hour that he or she sits at your consultation table, that's rubbish, that's nonsense. On the other hand, if we could mold in small tickers and markers during the rest of their life, even at work or during shopping or what have you, we all know that could improve the adherence for people to stick to it. And I think there's a couple of good examples in that also where a cross-industry approach could help. One of the great and one of my favorite examples, at least for the Netherlands, is that we know that people with high financial debt have a higher healthcare expenditure. They suffer from financial depressions and all kinds of other issues. So in the Netherlands, a big corporate bank collaborated with a big healthcare insurance company. And what they've done is they spread it, the debt, and the higher interest rate that was needed for it was paid by the healthcare insurance company, because they said the healthcare expenditure is going down, and with that we can pay for that, and the patient have a more at ease life, not suffering from depressions and everything that goes with it. And I think that's a great example. And one of the other examples, so that would be about the future of finance, for instance. And one of the other dear examples that I often use is about the future of food. We all know the impact of food for our health. And let's take somebody that suffers from cancer and has to go for a chemo round to the hospital. Whenever you're at the hospital, we take great care of you. You got besides physicians and nurses, we've got nutritionists and diets and everything that goes with it to make it as good as possible. But prior to your chemo round, prior to the moment when you're admitted to the hospital and afterwards, nothing goes. What would happen if we would be able to, in a secure and ethical way, the recipes of your chemo round, combined with the groceries that you would be doing at your grocery shop, that recipes that would benefit your recovery and your resilience to up that a bit more, other than just say, we'll fix that afterwards. So I think that's an interesting one. And maybe, and although this is a bit of a tricky one, Flavio, if something's healthcare related, what would happen if I, in my app of my big grocery store and supermarket, that all the things that would be bad for me all of a sudden would have a 10% price increase, and the ones that would be beneficial for me would have a 10% discount, you know, even without the supermarket not knowing that it's for me. But I think technology should be able to handle that. I could think that would be a very interesting approach. What do you think?
Very interesting approach. Kind of tricky one, you know, polemic one, but very interesting.
Yeah, you know, I agree. And I think public health and then tons of science projects and research have proven that, yes, we can change the minds of people, but there always has been one driver that really works. That's money.
Yeah. Yes.
And I'm not saying that we should start paying people, but that's where people feel it. And I'm not saying that is the end goal or whatever, but I think that's a field that we haven't been able to explore yet. And now maybe technology, whenever a patient/citizen has his own data, and there could be this formula that magically changes the prices at your supermarket, even for the supermarket that don't know about that, that would be an interesting one. And I see this collaboration with healthcare insurance companies, with supermarkets and banks, and so that's this cross-industry approach that I'm trying to get my head around. Work in process.
That leads us to this next question that is about linking the future of health. You use a table. I would like to share again this one.
I think that's a table that I was just talking about a bit.
Yeah,
about the future of health and all the other
Yes.
futures?
Yes.
Yeah, that's it.
This one.
Yeah.
It shows main concepts about the future of six big areas: food, work,
Yes, some of
mobility,
them.
finance. Yeah, some of them.
You could add tons of others. Yeah.
Yes, and we could talk about hours of these interactions, like the examples you gave us. I would like to focus on future of medicine here, because we are landing on this money, this financial importance that we just talked to. So regarding the future of medicine here, I would like you to talk briefly about each one of those bullet points here: personalized, delocalized, democratized, digital, insight-driven, prevention, prescriptive AI. And if I may add, this also relates with your Augmented Health book, because I can see here 3 of your 4 Ds of the future of healthcare: delocalized, democratized, and digital. But
one's missing.
Yes, that one you just talking about, dollars. Where does the money will come from for doing this reshape, and what about it?
Yeah. So, touching on those points, I think everybody gets personalized. We are able to have better diagnostics. We're able to tailor-made medicine and drugs specifically to patients. I think that's well known for everyone. Delocalizes that. I think that over the course of the next 10 to 15 years, healthcare will become delocalized. We are going to do interventions on a totally different place. At your home, at your wrist, on your bike, at your work. Things that up until now, we've only done within medical institutions, and that's the delocalized part on that. I really do think that, and one of the good examples I think is, for instance, Walmart Health, where you now see that Walmart is trying to consumerize some of the aspects of healthcare by giving you the opportunity to just walk into this Walmart Health clinic and get a GP consultation for $25, a total blood work for $35, and radiology for $45. So that's what I mean with delocalized. Things will be done in a different place. Democratize has all to do about data. We have more data in this small cell phone than I think has been done ever before. We are able to collect that data and make sense out of that. And like I said, you as a patient will grant your professional access and a subscription to the data that you have collected into your system. And that's a democratization aspect, because that also gives you the ability, like we as citizens had when things like booking.coms and all the other ones, all of a sudden with all the knowledge gave us the opportunity to vote with feet, as opposed to only by somebody advising us and prescribing us to go to a different physician. Digital, I think that's obvious in terms of the chat that we have, but it's also not only about technology, it's also about the speed. In, let's say, a couple of decades ago, not so long ago, you would need a missionary and a boat to get something from Europe to Africa. And now we got YouTube. So it's not only about the technology, it's also about the speed of it. Whenever somebody has access, indeed. So, and that also brings the next point, this insight-driven aspect. It's not a debate about data and AI and what have you, and I think that's perfect. But all of it does not make sense if it doesn't lead us to insights. Data alone is nothing. We need to make sense out of that, and out of that sense, we need to make it executable. Yeah. It doesn't have any value if you have, no matter how many AIs running, if it doesn't bring you an insight that you can execute on. And I think that's the interbellum where we are right now. We see these opportunities. AI systems are being pumped up. We're collecting tons of data, and now we need to make sense out of that, from information into insights into executables. That also gives us the opportunity for the next field that you touched on, from my slide, is the preventional aspect. Once we got those insights, we can measure and monitor earlier on and try to make sure that we can prevent a life event from happening.
Yeah.
I think a good example is the Apple Watch, and I, by the way, don't own any shares of all those companies, just to make sure. But now all of a sudden we can keep people, even though there's false positives, out of healthcare systems because we have this early stroke detection and what have you. And the last part I touched on in that is prescriptive AI. So prescriptive AI for me is more like it's a broader picture. If you just look at data, up until recently, we only had historic data that was enclosed in scientific literature. And based on that, we had this policy or protocol. Now we're in this era where we can act on recent data. Lab results from this morning, an MRI from yesterday, and we can interact sooner based on what we've seen, insight-driven. The next era will be on real-time data. And that gives us the opportunity to go from static data to predictive data into prescriptive data without the intervention of a real-life physician or nurse, but based on science, hardcore science, based on protocols to act prior to something from happening. I think that's the aspect of it.
Okay, and what about the last D?
Yeah.
Where does the money to make it all possible may come?
Well, first of all, I think that there's now this tendency, not only from governments, but also healthcare insurance companies, that they see the value of going to more to the front end of it, so the prevention aspect. And although I'm a kind of a fan of value-based healthcare, I think it's the wrong side of the equation. We really should strive to go to value-based health as opposed to the healthcare aspect. Because if there's this value-based health, and that brings in, first of all, you as a patient and you as a citizen to take care of your own responsibilities to stay as healthy as possible. Eat healthy, work out, we know the trick. Second, I think we need governments to make sure that we got this healthy environment. That's, of course, from a public health perspective, a very broad aspect of it. Thirdly, and we did not touch upon that yet, but it's also in my future of work aspect, employers. We've now seen also during this COVID pandemic that all of a sudden, also the role of employers in keeping their employees healthy also at their homes, for instance, now working from home, really also brings in this responsibility. And I think in the next, let's say, decade, we will see again an uprise of the quote-unquote old-fashioned corporate medical teams that we've outsourced in the last couple of decades, bringing convenience to you as an employee of your company, that you could take your blood work at your own company, so you don't have to go out for that. Hence, that's the delocalization aspect of it. Also, that employers will also take a stake into keeping you healthy, so you would choose for them to work for as opposed to somebody else. Corporate benefits. And it brings in all kinds of tricky questions as well, of course. So I think that the payment system of that is that we will go and make a shift to the front end of it and also be able to pay with that. I think it's cheaper to keep somebody with COPD out of an exacerbation than to treat him afterwards. And I'm not an economist, so I did not do the calculation on that, so I could not tell you the numbers. Maybe I should ask an economist to do that once for me, so just to give an example of it. But I really do think that it really does work.
No doubt about it.
To give you another example on that, how to pay on it, and this is a bit of a detour in it. In the Netherlands alone, and these are number of 2015, that's a while ago, we had 8.8 million first outpatient clinic visits that year. 8.8 million for first outpatient visits. So that would bring you to the hospital and back. So that's like 19 million. The average distance in the Netherlands to a hospital is like 5 kilometers. So if you would run the math, that would be 91 million kilometers, Flavio, in 1 year. Just think about all the environmental aspects on that. Think about all the real estate that we should build. Think about, and on the other hand, if only 5% of all those visits would have been done through video conference like we're doing right now, it would save us as much as 200 parking lots a day. That's a whole parking garage that they're building for 1.5 million. So it's back to the dollar question. It's also reallocating where we put the money in.
Perfect. Perfect, Lucien. I think we're good. We're good here. We walked through all those questions I would like to ask you, and was a very pleasant talk.
Well, I've really liked it. Thank you very much. It's always great to talk to you guys and with people with great questions and tough questions as well.
Nice. So, Lucien, thank you very much once again.
Thank you.
Couldn't thank you enough for being here. And well,